Thank you very much for your fascinating lecture. And we will move now to the next lecture entitled Reverse Personalized Immuno-Oncology, Critical Thinking, Collaboration, Ingenuity, Leadership, and Innovation. And the lecture will be given by Professor Gal Markel, one of the promising scientists in Tel Aviv University and in Israel. Gal is now the Deputy Director. I say now because until 5 months ago he was in the Sheba Medical Center, and now he's the Deputy Director General Rabin Medical Center and Director of Davidoff Center for the Treatment of and Research of Cancer. He is a member of the Department of Clinical Microbiology and Immunology at our university, and really a combination of a clinician and scientist and innovator. And Gal, the podium is yours.
Thank you very much, Dean Grossman. Yesterday I forgot. Also, I think it's exactly due to the same reason. We are used to go with it the entire day, the entire full day in the hospital. So it's I think it became like another organ.
Like glasses.
Like glasses, yeah. So, but it's great to speak without it. It is truly a pleasure and an honor to be here today. Thank you for the invitation. And to come after a speaker like Wayne, it's always hard. But I think that what I'm going to talk about, it actually interacts with some of the topics that Dr. Jonas described, but unfortunately not in the healthy population, but rather at the population that I deal with, and that's patients with cancer already diagnosed. This is the top of the pyramid that you described, but this is the field that I deal with every day, and I will try to describe some sort of a journey of how to try and deal with this sort of illness from standard pharmacology and all the way to some sort of out-of-the-box thinking, trying to modify the whole person in order to deal with cancer. So this is the way that we treat cancer patients in our everyday clinics. We give chemotherapy. That's one size fits all, but we know that one size fits all hardly ever fits anyone, and that's the same thing with chemotherapy. It rarely cures patients. And over the last 2 decades, we started to shift from chemotherapy to what we call personalized cancer therapy. And in oncology specifically, the idea is to develop specific drugs that deal with specific features of cancer. And that's a great way to move forward with understanding of biology and developing of treatments. And this is what we've been doing for about 2 decades with great success. But the problem is that the more we dip into this strategy, we find out that we deal with narrowing down of populations. We develop drugs for 0.5% of the lung cancer patients. And we still need to go through the whole process of drug development and the full resources that are required for that. So we thought, okay, maybe we need to think about it from an entirely different angle. Maybe we need, instead of tailoring drugs to patients, maybe we need to tailor patients to drugs, and not just in the sense of matching the populations based on markers. And this is what we rely on. That's the immune system, and that's the best real-time personalized medicine machine. Within just a few days or weeks, the immune system can generate the ultimate internal drug or internal power to eradicate cancer. And today we have already approved medications, drugs. They are called immunotherapy, which can effectively harness the immune system. And we can treat many types of cancer with immunotherapy. But that's the problem. The problem is that we can benefit only around 1/3 of the patients. Still 2/3 of the patients do not really benefit from this wonderful strategy. And we ask ourselves, why is that? Can we do something to the patient and modify the patient and render the patient and render the resistant patients, the refractory patients, can we render them sensitive to the same immunotherapy that works for the other third? So that's the question. That was the challenge. So how can we address, how can we approach such a question? So what we did here, and that's a huge collaborative study with multiple teams in Sheba and in Tel Aviv University and with other hospitals, in which what we did was to analyze a triple-digit number of melanoma specimens of patients that were treated with immunotherapy prior to the treatment, and we asked ourselves, what differs between those who responded and those who did not respond? And we looked at different levels, at genetic level, at proteomic level, at the tissue level, at the clinical level, and we tried to understand what's going on. And that's a paper that we published in Cell, and we analyzed first the proteomics at the protein level. And the protein level told us something, a very interesting story. We found that tumors with aerobic metabolism, that's associated with response, and tumors with anaerobic metabolism is associated with failure of treatment. And of course, I cannot go into all of the details, but the idea was, was to try and tackle this question from a mechanistic perspective. What we can see here, it's one of the experiments in which we pushed or we engineered the melanoma cells to operate under anaerobic metabolism, and we found out in animal models, for example, that the tumors become aggressive and with very low immunological markers. So that's a mechanistic a cause and effect. It's not just a statistical association. So anaerobic metabolism reduces the immune recognition, and that causes immune resistance. And indeed, in patients, we see it enriched among patients who progress with the disease which is refractory to immunotherapy. So maybe what we need to do is to take those anaerobic conditions and push them towards aerobic conditions and thereby restore immune sensitivity. Now, we also looked at the genetic, at the gene programs level. And that's a work done by Itai from my lab. And Itai was able to process a great deal of information, and he found out that we can identify 3 types of gene programs. One he called immune response, because these programs were associated with response to immunotherapy. This is immune cells, and the third one he called immune resistance. And of course, we were interested in immune resistance. Those who respond, they respond. We want now to focus on those who do not respond. And what Itai studied, he tried to find what is the key component that drives this immune resistance. And he found out that that's a protein that all of us who comes from medicine or biology, we are familiar with MYC. MYC is a very well-known oncogene that drives cancer, but it turns out that it doesn't just drive cancer forward, it also drives resistance to the immune system. And we can see it, this is an example of tissue from a non-responder with very high levels of MYC. And Ortal was able to prove that when she took, now in cell models, when she introduced this MYC protein, the cells become resistant to the immune system. So we can see now a cause and effect. So the conclusion is that MYC, this oncogene, famous oncogene, it reduces immune responsiveness, and thereby this causes immune resistance, and therefore we can find it indeed among immunotherapy patients with a failure of immunotherapy. So high MYC, maybe what we should do is to reduce or inhibit MYC and thereby restore immunotherapy. Now going into some clinical relevance. Can you really do it? And that's, I think that you're familiar with this motto. So connecting everything could also be not only for Broadcom, but also for us. So if we know from the literature that MYC drives anaerobic metabolism and also immune resistance, and we know that there is an intracellular wiring program which is very dominant in cancer, which drives both of those aspects, we can see that everything connects to failure of immunotherapy. So we focused on this thing, and we tried to block this pathway. And there are drugs that do it. We know that. And Hannah is a PhD student in my lab, and he has been using those anti-MAP kinase drugs, And lo and behold, he shows that when he applies those drugs on the melanoma cells, they become sensitive to the immune system because he was able to reverse all of that. And it can be shown here. So that's in the lab, but what about the clinic? So this is a patient of mine that I treated, and she had metastatic melanoma, and I treated her with immunotherapy, and it didn't work. And then what I decided to do was to continue with immunotherapy and just apply those medications for a transient period of time. And the results were very interesting because the disease started to regress. And it regressed all the way to a complete response, and she's still in complete response. And this is not the only patient that we did it. But we need to prove it in a more methodical way, and now we have a clinical trial on its way that is going to test exactly that. But that's medications. Can we do something more holistic? I was talking about metabolism, so anaerobic metabolism to aerobic metabolism, maybe we can modify it with dietary modifications. For example, ketogenic diet. And I don't know whether it's a good diet or not, but what we do know is that ketogenic diet can drive aerobic metabolism. It drives beta oxidation, and we showed already in the lab that conditions that mimic ketogenic diet actually stimulates immune proteins and immune sensitivity. So now we have on its way a clinical trial program, a two-stage clinical trial program that in which we try to see whether indeed ketogenic diet can affect immune response to immunotherapy. And coming now to the last part, and that's the generalized concept. Can we modify the full patient not only with ketogenic diets or other diets, but also in a different way? So Erez, who completed his PhD also in our lab, he also looked at the genetic programs, but he was focused on the immune system, and he found something very interesting. He found that immune system with a responding programs to bacteria, these programs are associated with response. And that led us to think about the microbiome. This is how we got to this field. And the microbiome, this is a very big field today. The microbiome is the collective bacteria in this case who reside naturally with us. And the vast majority of them reside within the gastrointestinal tract. And just for you to comprehend, it is about 3 to 4% of our weight. And there are at least 100 times more bacterial cells as compared to our cells. So we are 90% microbiome cells and just 10% of us. So come to think about it, it's pretty robust. And we know today that the microbiome has very intricate relationship with the immune system. Now, just thinking about these figures, we understand why. So the microbiome, we know today that it can shape the immune system. So if it can shape the immune system, can we reprogram the immune system in a patient by altering the microbiome and reprogramming the immune system and thereby get a clinical response? So how can we alter the microbiome? There are multiple ways to do it. We decided to go for the full spectrum, and the way to do it is called fecal microbial transplantation. And that's, it's exactly what it sounds and what you can see. And it is an approved procedure. It is used in modern medicine in order to treat refractory or resistant cases of certain bowel infections. And there is it is approved for resistant Clostridium difficile infections, and there is a Hoser Markel. It's approved in Israel and in other places in the world. It exists. So we thought, okay, let's take the easy way. It's approved. All we need to do is just to keep it aside. And instead of using microbiome from healthy individuals, we decided to take the road under this hypothesis. If indeed the microbiome is so important and shapes the immune system, maybe what we need to do is to take the microbiome from those wonderful responders to immunotherapy and transplant the microbiome in the patients with a refractory disease. If this is indeed the cause and effect, when we do the FMT, the transplantation, and give again the same immunotherapy that didn't work earlier, something should happen. And everybody thought that we were a bit crazy in the beginning. And Wayne, I think that you were among the first people who heard that we are going to do that when we were in Germany. And we had 2 donors, and this is the analysis of their microbiome, completely different. We have absolutely no idea what's going on here. Completely different microbiomes. And this is a very, very busy slide. The only thing it means to show is that we treated 10 patients who didn't have any other hope. They received everything several times, with high burden of disease, with metastases in the brain, in other places, very hard population to treat. And the protocol was FMT and, again, immunotherapy. So this is a very safe protocol. No really significant side effects from the FMT or from the immunotherapy itself. And this slide shows the first question. Can we really alter the microbiome? So what we see here, these are, it's called a variability plot. And this is the microbiome of donor number 1, this is donor number 2, these are the recipients of donor number 1, and these are the recipients of donor number 2. Before the protocol, we can't distinguish between among them. But after the protocol, donor 1 recipients are clustered here, donor 2 recipients are clustered there. We alter their microbiome. And the altered microbiome also, it changed the patient. It changed the patient's immune system. What you see here in brown is these are immune cells in the gut. These are immune cells, okay? And you can see the increase, and that happened 9 out of 10 patients. And it didn't end just there. Also, in 6 out of 10 patients, the more important immunological phenomenon occurred, and that's an immune infiltration of the tumors. It's very clear why immunotherapy didn't work here. There are no immune cells. Look what happens after just 2 months. And now comes really the surprising, at least when we saw it, we were surprised, and that's clinical activity. 3 out of 10 patients, they exhibited objective disease regression, 2 partial responders and 1 complete responder, and this complete responder is already almost 3 years with a complete response. I hope that he is cured. We don't know yet, but that's really phenomenal. And we are now moving forward, and we are moving forward with ELA Therapeutics. And this is how ELA Therapeutic works. It's a very unique model, because typically in medicine, we start from the lab, then to animal models, then to patients. Over here, we start with patients. The patients are our lab, and we are moving forward with 40 patients in Israel, probably additional 12 patients in the United States, and we are creating causative data sets. And on the go, we are benefiting patients. The basic research, the lab, we are benefiting patients. Already we have responders in the new trial. And that's something that I personally, I've never got a chance to experience something like that. And the idea, in the end, the idea would be to reverse engineer and understand which bacteria are important, which metabolites are important, etc. And with that, I'd like to end. And over here, you can see the many many of our founders of the story that I told you, and among them also the Samueli Foundation. And I'd like to thank you, and Susan and Henry, and to thank you for your attention.